Good afternoon, everybody. So we welcome you all to another edition of our PG Masterclass for this month. And our president, Dr. Bharti Malhotra, has also joined. Ma'am.
Hi, good evening, everyone.
Good evening, ma'am.
Good evening. तो
आवाज नहीं आ रही, आप शायद म्यूटेड है.
नहीं, आवाज अभी करती हूँ. ओके, आ रही है आवाज?
Ma'am, we can't.
I can hear.
I can.
हाँ, I can hear you now.
चलो, great series you are conducting, Sonal, and welcome to Sumita.
Thank you.
And very nice topic she's chosen, because we are not all the time we are hearing more on AMR and AMSP. So this is really a nice welcome topic. So thanks for choosing a good speaker and a good topic. So you can continue now.
All right. So introducing the speaker, Dr. Sumita Khurana is Professor and Head, Department of Medical Parasitology at PGIM at Chandigarh. An excellent researcher, a very, very good friend for a very long time now, almost 12 years since we know each other, Sumita.
Yeah, thank you.
Welcome to this PG Masterclass, and I'm sure it's going to be a very good knowledge gainer for all the students across the country. So over to you without wasting any more time.
Thank you so much, Dr. Sonal, and it's a privilege and a pleasure to be part of this IAMM PG program, and I'm thankful to IAM for the same. And so I begin with the topic. So what I want to say is that though free-living amoebae cause infections which are rare right now, but they are emerging, and with the increasing global temperatures, it's likely to increase even further. So what, as is said, that what mind doesn't know, eyes don't see. So it's better, and it's very important to be aware and to know in detail about these free living infections, because we are seeing a lot of infections due to these free living amoeba these days. And you must have read it yesterday or day before yesterday in the newspaper where a Kerala girl died of this brain-eating amoeba. So this meningoencephalitis, which is a brain-eating amoeba, is a free-living amoeba, and a lot of fatal infections are caused by this. So coming back to the topic, so this free-living amoeba are opportunistic, emphyzoid meaning that they are capable of surviving very well in the environment only without the host also, but they are quite adapted to being inside the host also, and they are found globally. So no part, probably apart from Antarctica, they are found everywhere in the world. And they have been isolated from different environmental sources like water, soil, air, everywhere. And they have a wide range of growth conditions. They can very well survive in a whole range of pH and temperatures, and especially meningoencephalitis is known to survive very well in higher temperatures, and temperatures up to 42 degrees centigrade. So that's the reason why these infections are more commonly seen in summer season, and is normally associated with swimming in the wild. So I'll come back to that again. And another important thing about these free-living amoeba is that apart from being pathogens themselves, they also serve as hosts for many pathogens, especially some bacterial pathogens. And this phenomena is called as the Trojan horse phenomena, where these bacteria survive inside these amoeba, and they don't just survive, they even increase their own virulence and virulence of amoeba by residing inside amoeba. And Legionella is very well known to survive very well in Acanthamoeba, and it has been documented that many pneumonias and infections due to Legionella are attributed to their presence inside the amoeba. And in addition to being present, these present inside amoeba, they also get protection from the host immune system by being intracellular in the amoeba. Thus, these free-living amoeba play important role in etiology and spread of bacterial diseases in addition to they themselves causing diseases. So if we look at free living amoeba broadly, they are categorized into Acanthamoeba, Naegleria, Balamuthia, Sepinia. These are the ones which have been implicated in disease mostly. And then the non-pathogenic Hardmanella, worm amoeba, and few more genera also. Though lately worm amoeba has been documented to cause keratitis in a few cases. However, most of the free living amoeba infections are attributed to Acanthamoeba, Naegleria, and Balamuthia, and only one case report of Sepinia has been documented. So, if you look at the classification, they are all protozoa, and the Naegleria falls in the order Schizopyrinida, while these Acanthamoeba, Balamuthia, they fall in the order Amoebida, which also contains the Entamoeba. So now, a little bit about the history of Acanthamoeba. It was, actually, they were these free-living amoebae were isolated incidentally, and in 1913, Pushkarov isolated an amoeba from dust and named it Amoeba polyphagus. And in 1930, actually, Castellana isolated amoeba as contaminant from yeast culture. But infections were documented later. And the infections were due to these free living amoebae were documented later, and slowly the awareness about these amoebae causing infections and diseases got attention of scientists. If you look at the morphology of these free living amoebae, actually there are two main morphological stages. One is the actively moving and feeding trophozoite stage, and the environmentally resilient cystic stage. In addition, Naegleria has a third transient flagellate stage, and hence Naegleria is also called an amoeboflagellate. And that is a very distinguishing feature of Naegleria, which differentiates it from all other free-living amoebae. If you talk about the size of Acanthamoeba and Balamuthia is quite similar, ranging from about 15 to 30 to even up to 60 micrometer, while the Naegleria is the smaller one, ranging in size only from 7 to 15 micrometer in size. Though the cysts are more or less similar in size in both Acanthamoeba, Naegleria, and Balamuthia, and ranging in size from about 10 to 15 micrometer in diameter. And Acanthamoeba has been actually differentiated into a number of species, but latest concept is more of the genotypes, because species have been known not to fall in one particular genotype belonging to different species. So the genotype concept is more accepted these days, and 22 genotypes of Acanthamoeba are known based on their 18S ribosomal RNA gene structure. And it is the certain types are more commonly associated with infections, whether you call it the eye infections or CNS infections. And T4, the T4 genotype is the most predominant genotype, which is one present in the environment, and also which is the one which is associated with most of the infections. In one of our studies also, we found that all the Acanthamoeba keratitis, 57% of our isolates were because of T4 genotype, while 40% of the infections of central nervous system were because of T4 genotype in our study. And other genotypes which were associated with infections were T11, T5, and T10 in our study. So how is this infection acquired? The Acanthamoeba infection is acquired infection is acquired through the cyst, either by inhalation of cyst or by ingestion. Though ingestion is not a common route, it's not actually documented to be a very documented route of infection. So the CNS infection is acquired through breaks in the skin. So it is the skin lesion which is actually responsible for further causing infection in the brain, and also through nasal passages to the lower respiratory tract. But the eye infections are caused by direct inoculation into the eye, either by swimming or by contaminated contact lenses, or by injury to eye through various, the agricultural material, or through dust and etc. So the keratitis never leads to CNS infection. So it is important to remember that keratitis is a standalone entity. It never leads to the CNS infection. One thing which is important to note here is that the CNS infections due to Acanthamoeba are seen mainly in immunocompromised patients. Though there are reports of infections in immunocompetent individuals also, but most of these individuals have some kind of underlying disorder or chronic disease, like it could be alcoholism, diabetes, or immunosuppression due to various causes, and even malnutrition is a risk factor for CNS infections. While in case of Acanthamoeba keratitis, it is seen in healthy individuals. So I will be coming to that later. So there are basically three common entities caused by Acanthamoeba. One is the infection of the eye, that is the Acanthamoeba keratitis. Then CNS infection, which is described as granulomatous amoebic encephalitis, and also the cutaneous disease. And actually, it is the cutaneous route which is actually leading to CNS infection. So if we talk about the epidemiology of Acanthamoeba keratitis, as you know that infectious keratitis as such is a leading cause of corneal blindness in both developed as well as developing countries, with an estimated incidence of 2.5 to 799 per lakh population. And incidence of Acanthamoeba keratitis is estimated to range from 1 to 3% of all infectious keratitis. Most of the infectious keratitis is because of either bacteria or fungal or viral etiology. And in developing countries, the fungal etiology is more common as cause of keratitis, while in developed world it is the bacterial or viral etiology which is more common. And it is more in the developed world. It is more common in Acanthamoeba keratitis is more common in people who use contact lenses. And 85% of infections are seen in contact lens wearers. Whereas in India and in other developing world, contact lens wear is not all that common. And here the Acanthamoeba keratitis is most commonly seen in agriculturists as a result of ocular trauma with vegetative matter, and also on exposure to contaminated water, use of traditional eye medicines, splashing contaminated water into eye, corneal injury with mud, etc. And even in our study, we found that only 25% of our individuals had history of contact lens wear, and 75% of the individuals had other risk factors like being agriculturists or having some other surgeries or dry eye syndrome. And if you look at the various reports of Acanthamoeba keratitis from various parts of India, the studies put the prevalence from 0.4 to 4.8% from different parts of India. And risk factors I've already talked about, that is the use of contact lens, especially when the hygiene of contact lens is poor, and use of homemade solutions and wearing lens while swimming. And other risk factors are corneal trauma or post-surgery. So this particular study, 36% of the individuals with the Acanthamoeba keratitis were agriculturists. Now, Acanthamoeba keratitis is known to be associated with other bacterial infections also, and it is estimated that at least 15 to 20% of individuals who have Acanthamoeba keratitis also have associated bacterial infection, which should be concurrently treated. And if you look at the pathogenesis, actually, there are a number of contact-dependent and contact-independent mechanisms by which this Acanthamoeba produces its pathogenicity. One by way of adhering to the mannose binding protein of cornea, and then since it's an amoeba, it has pseudopodia. It is capable of phagocytosis, and actually, Acanthamoeba is said to be an evolutionary cousin of macrophage only, and in many ways, Acanthamoeba resembles macrophage, and in samples also, it is important to differentiate Acanthamoeba from macrophages, and which may sometimes and many times may be difficult. So, those are the contact-dependent mechanisms of pathogenicity. In addition, Acanthamoeba has a huge array of enzymes which it produces, which includes proteases and phospholipases of various kinds, including cysteine proteases, which are the most potent proteases in the microbial world. And in addition, there are many other indirect virulence factors like phenotypic switching and its tolerance to huge range of pH and salinity, etc., drug resistance, etc. Nevertheless, the infections are not very common in a host, but they are increasingly being reported. And this is the slide to show the pathogenesis, wherein the Acanthamoeba actually, first of all, binds to mannose binding protein on the corneal epithelium, ingests bacteria which are there in the normal flora of eye, and then it releases certain enzymes and proteins which are capable of degrading the corneal epithelial cells, which this destruction of corneal epithelial cells in turn produces immunological reaction, and immune cells are deployed to the site of injury, which itself is another cause of immune-related injury. So as a result, a lot of inflammation takes place, and there is destruction of corneal stroma, and corneal melt also is a very prominent feature of Acanthamoeba keratitis. So if you look at the signs and symptoms are not very different. However, one feature which is characteristic of Acanthamoeba keratitis is severe pain, and this pain is disproportionately more in comparison to the clinical signs which are there. The person complains of unbearable pain. In addition, there is reduced corneal sensation, epithelial defects, erosions are seen in almost 60% of the cases. There is a characteristic stromal ring infiltrate, but sadly, this is only seen in 6 to 29% of patients. So, it may not be very easy to pinpoint the diagnosis as Acanthamoeba keratitis initially. And most of the initial picture resembles that of herpes, like herpes keratitis or keratoconjunctivitis. Limbitis is also seen in majority of individuals. And in the late disease, because Acanthamoeba infection is known to persist for a long time, and most of the times it is first treated as viral or bacterial and fungal, and then only most of the clinicians start suspecting Acanthamoeba keratitis. So most of the time, the disease is of more than 1 month duration, and then this leads to secondary uveitis, ulceration, and corneal melt and corneal perforation. And most of the times, 30% of the times, the patients need to undergo keratoplasty because of the corneal perforation or corneal melt which occurs. So how you diagnose? Here the role of microbiologist is very important for diagnosis of Acanthamoeba keratitis. And here the sample type is very important. Corneal scrapings are the most important samples for corneal biopsy. Though contact lens and contact lens cleaning solutions may also be used, however, just mere presence of Acanthamoeba in contact lens and cleaning solution does not actually does not actually implicate Acanthamoeba as the cause of keratitis. So it is very important to isolate Acanthamoeba from the corneal sample, from corneal scraping. Even so many times we just get a slide of corneal scraping and we scrape out material from there, do the DNA extraction and do PCR, and even with very minuscule material, we are able to amplify DNA of Acanthamoeba and thus help in diagnosing the patient. Another important thing is the microscopy. If you get, because corneal scraping is usually scanned, so it may not be possible always to get a good amount of sample, and you can't do the ideal things like if the sample is available, you should do microscopy, put it on culture, and then do PCR. Many a times what we do is that first we do microscopy, first we do culture and then microscopy, and from the microscopic slide only we scrape the material off and use it for DNA extraction and do PCR. So the culture is on non-nutrient agar with the lawn of bacteria, could be E. coli or Enterobacter or any other bacteria. And the trophozoites are characterized by polymorphic shape with large nucleus, having large central nucleolus, and a lot of contractile vacuoles which surround the nucleus actually. And a lot of spiny acanthopodia are characteristic of Acanthamoeba. So one could directly visualize amoeba in corneal scrapings or do some kind of staining like the calcofluor staining is very good for picking up cysts. But trophozoites will not be picked up in calcofluor staining. One could do acridine orange and other stainings like hematoxylin, eosin, Masson's trichrome, wherein you can see both trophozoites and cysts. However, calcofluor white is a very rapid and good technique for picking up cysts very fast from a corneal scraping, because most of the times for fungus the sample comes for the fungus examination also, and for that we do calcofluor staining. So even a Acanthamoeba cyst can be easily picked up on calcofluor staining. Then confocal microscopy, which is available actually with the clinician, that is possible, and Acanthamoeba cysts appear as well-defined hyperreflective spherical structures, but trophozoites may be difficult to distinguish from leukocytes and keratocyte nuclei in confocal microscopy. And PCR is another tool that we microbiologists have now. And in our studies also, we found that microscopy has a sensitivity of somewhere around 60-70%. Culture has a sensitivity of about 81%, but PCR and real-time PCR and lab have very good sensitivity of about 100%, and where the material is scanty and not enough for culture or there even DNA extraction and PCR is a very useful tool. And we've seen even lab has a very good sensitivity and specificity. Even we have used MALDI for protein profiling of Acanthamoeba species, and we could put them and we could differentiate the environmental isolates of Acanthamoeba from the pathogenic ones using the MALDI profiles. And we've established an animal model of Acanthamoeba keratitis also. Previously, the model had been made with the use of specially made lenses which have to be which have to be designed and manufactured commercially, and they are very expensive because the eye of my mouse is very small. So the normal human lens does not fit the mouse eye, but we used the parafilm, which is used, to cover the culture plates and other things. We use parafilm as the experimental model for reducing keratitis in mouse model. And coming to treatment, the treatment is the thing about Acanthamoeba keratitis is that it is very difficult to treat. Reason being, the diagnosis is usually delayed, and the effective antimicrobials are scarce. And the clinical picture initially is very similar to other etiologies. So it's not actually suspected in the beginning. And when the patient presents, already complications are there, and at that time, it is the antimicrobial just don't work. Another thing about treatment is that a prolonged treatment is required. And usually a combination of drugs is required. And in spite of prolonged treatment, it is associated with poor visual outcomes, and approximately 50% of contact lens users may lose sight from microbial keratitis, and Acanthamoeba is one of those main agents which are responsible for this. And there are reports of about 5 to 10% of cases being refractory even to extended courses of combination therapy. And stromal keratoplasty is the thing which is actually required in conjunction with the medical treatment in most patients. And the drugs which are commonly used are chlorhexidine plus bromelain combination or PHMB. Actually, PHMB is considered, I'm not taking the full name, it's a very complicated full name, so it's difficult to remember that. So PHMB you can remember at a concentration of 0.0 to 0.06% has to be given hourly, round the clock, and then tapered off. But then the duration is given till the patient is clinically asymptomatic or or the subsequent culture or examination of eye is negative. Other substances can also be used like hexamidine, ketoconazoles, etc. The other imidazoles have also been used, however, they are not as useful as the PHMB and chlorhexidine. Steroid should be avoided as far as possible, but it may be used in conjunction and under cover of anti-amoebicidal and anti-microbial agents. There is the orphan drug for Acanthamoeba keratitis trial, which was PHMB 0.08% and placebo versus PHMB 0.02% and propamimide. And it was found in this study, the trial of this result showed that PHMB at 0.08% monotherapy is as effective as propamidine. So FDA has also granted orphan drug status to oral miltefosine. So miltefosine, which is a drug usually used for leishmania treatment, is also quite effective for treatment of Acanthamoeba, not just Acanthamoeba keratitis, but also in CNS infections that I would be talking about slowly. The prevention is by common sense things like contact lens hygiene and not swimming with lenses on, etc., and not swimming in contaminated water. Now coming to the CNS infections and due to Acanthamoeba, the infection due to Acanthamoeba is called Granulomatous amoebic encephalitis, and as I already said that this condition is caused not just by Acanthamoeba but also by Balamuthia, which causes the same Granulomatous amoebic encephalitis. And both of the Acanthamoeba and Balamuthia look similar, except Acanthamoeba has spiny pseudopodia while Balamuthia has spider-like pseudopodia. And Acanthamoeba does not grow on Acanthamoeba grows on NNA medium while Balamuthia does not grow on NNA medium. So that's one thing which microbiologists should remember, that Balamuthia would not grow on your NNA medium, and for that you will have to either do tissue culture or other molecular techniques or microscopy can be helpful for its diagnosis. Now, this is a serious infection of the brain and normally occurs in immunocompromised individuals, and the predisposing factors include age, bone marrow transplant, steroid therapy, or any kind of immunosuppression therapy. And the parasite enters either through the breaks in the skin or through the neuroepithelium, olfactory neuroepithelium through the nasal. But skin route is said to be more common, and hematogenous dissemination is considered to be more important route for Acanthamoeba granulomatous amoebic encephalitis. As I already said, it produces a number of enzymes and has a wide array of virulence factors through which it gains entry into CNS by breaking the blood-brain barrier and entering the brain. And if you look at the size of trophozoite is about 50 to 30 up to 60 micron with typical Acanthamoeba, while this start 10 to 15 microns in stage. And a number of case reports of Acanthamoeba GAE have been reported from India. Almost 50 to 42 cases we compiled till last year, and more than 25 cases of Naegleria and 4 cases of Balamuthia we compiled. And the Acanthamoeba infection is associated with a lot of morbidity and mortality. It has a subacute or chronic course, and ranging the onset is takes about 7 days to 5 months. So it is difficult to track or trace the source of infection, because by the time the disease develops, one does not remember, or one may not associate that with the source. But it leads to slowly the CNS manifestations appear, and they are like that of encephalitis. And any of the, depending on the part of brain involved, the symptoms would develop, and it could be just confusion or visual disturbances or various palsies, seizures, coma, along with fever. So the history of swimming in contaminated water may not be typical, and it is recommended that one must examine the patient for cutaneous lesions, because most of the times route of infection is transcutaneous. And the important thing here is that parasite may not be seen in the CSF, because it is causing encephalitis, and more trophozoite cells could be seen in the tissues if a biopsy could be taken, but presence of trophozoites or cysts may not be there in CSF. So a negative CSF actually does not rule out Acanthamoeba, Granulomatous, amoebic encephalitis. So it is important to keep in mind, and in about half of the patients, CSF may be negative for these parasites. But one has to look for other signs of infection, because the clinical signs also, the clinical symptoms and signs are indistinguishable from those of other infections. And the diagnosis is made by visualization of parasites or the culture in the NNA medium, as I said earlier, or using various tissue stains. Then CT or MRI give a lead by demonstration of hypointense lesions associated with edema, hemorrhages. And the PCR also plays a very important role, because it is capable of picking up very minuscule quantities of parasite in the sample. So most of the times microbiology would receive a CSF sample, and the sample may be microscopy negative, but the parasite may grow on culture or on PCR. Another entity which we saw in one patient was osteocutaneous Acanthamoeba in an immunocompetent individuals, and then we've seen a number of cases in the immunocompromised individuals. Then coming to another entity, that is Naegleria. Now the thing to remember here is that Naegleria causes meningitis. It causes acute infection in comparison to encephalitis, which is a subacute or chronic infection caused by Acanthamoeba or Balamuthia. So Naegleria, the patient gives a very short history, and the history may be typical of swimming in say ponds or lakes, or also associated with use of native pots. Last year we had helped diagnose few cases of Acanthamoeba and Naegleria infections in a particular with the use of particular religious ablution in Kerala region, and the parasites were isolated not just from the patients but also from the water source in which this ablution was done. And so it is very important to be aware of presence of these parasites in in the untreated water, in ponds, lakes, and especially in the summer season, where because the Naegleria is capable of surviving in high temperatures in comparison to other organisms. And nearly 300 PAM cases have been reported worldwide. PAM is associated with a very poor prognosis and almost invariably leads to death. And the time of disease onset to fatality is as low as 1 week or 9 to 10 days. So most of the time, by the time diagnosis is made, the patient is already dying or dead. And the diagnosis is usually made post-mortem. Here I said that another temporary flagellate stage is also seen in this Naegleria, and it is commonly, this amoeba is commonly known as the brain-eating amoeba, as you see in most of the pictures in journals or newspapers. Or here the mode of infection most commonly is through nasal route, not skin, which is the most common route in case of Acanthamoeba. So swimming in contaminated water is the most common way by which most of the patients acquire this. And since the history is very short, you are able to elicit this kind of history in Naegleria patients. Initially there is infection of the nasal stage, and one thing I would like to mention here is that the Naegleria cysts are also present in the nasal cavity as carriers in many individuals, and even anti-amoebic antibodies have been documented in almost 100% of the patients. So it's not that the exposure to these amoeba is not common; it is common, but only under certain conditions the infection leads to disease. And the immunocompromised state, or maybe the load of parasite, burden of parasite in the source is very important. So here the presentation is very acute. So initially it is thought to be as bacterial or viral infection. The signs and symptoms are not characteristic, but there are some differential features which can point towards Naegleria infection. That is absence of bacteria or virus and presence of blood in the CSF tap in absence of a traumatic tap. Sometimes the tap is traumatic, so you do get RBCs. But if the tap is not traumatic, but you are seeing RBCs in the CSF, that's an indication of these free-living amoebic infections. And in case of a Naegleria infection PAM, the picture resembles like that of viral, wherein the glucose is normal to low, but the proteins are little bit elevated. The proteins are elevated. So it is important to suspect that it could be amoebic infection, and hence put up appropriate tests. And Naegleria grows very well in culture. The trophocytes are smaller than that of Acanthamoeba. The cysts are also smaller, and it is said that the cysts move also. They are also a little bit smaller than that of Acanthamoeba, and if you keep on looking, even the cyst of Naegleria move a little bit. You could see these parasites by wet mount or in culture or by specific staining techniques like HNE, trichrome, or by immunofluorescence stainings, or else by PCR. So in this study, we have established molecular diagnosis by way of PAN primers, PAN FLA free-living amoeba primers, as well as confirming them by the genus-specific primers. And prevention is the common sense things like drinking adequate chlorination. It is recommended that drinking water at 15 parts per million of chlorine, and in swimming pools there should be 30 parts per million of chlorine. If these values are, then the water is considered safe for consumption or for swimming. And Balamuthia is another parasite which causes infections resembling that of Acanthamoeba. Though it is less common compared to Acanthamoeba, we see a lot of Acanthamoeba keratitis nowadays, almost 2 to 3 cases per month. Acanthamoeba CNS infections, not very common, but maybe once or twice in a year we do see. Balamuthia we don't see very commonly. However, we have reported 4 cases over last decade, 4 cases of Balamuthia meningoencephalitis. It also has the similar stages as Acanthamoeba. The one difference here is that trophozoite has spider-like pseudopodia, and the cyst is a triple layer cyst. And Balamuthia does not grow on culture. So that is one thing which is to remember. The mode of infection is similar to that of other amoebae, and diagnosis is similar, except that you can't do culture on NNA medium. You could do it on mammalian cell cultures like monkey kidney cells, human fibroblasts, etc. And then PCR is always there. Radiology is a big support for any infection of CNS. Then Sepinia is another parasite. Only 1 case report due to Sepinia, and the person was saved. The person is alive. And so I won't go too much into detail. It is also a bigger amoeba compared to other amoebae, Acanthamoeba and Balamuthia. And the cysts and trophozoites possess 2 nuclei. So hence diploidia. Otherwise, other Acanthamoeba, Naegleria, and Balamuthia possess 1 nucleus. And this was a single well-documented case in 1998. 38-year-old man from Texas who survived, and he was diagnosed as infection caused by diploidia. And in 2009, infection was re-identified. The same patient, the parasite was re-identified by as Sepinia pitatim or diploidia. So how do you manage these CNS infections? See, since there cannot be any case studies or proper trials because of the rarity of these conditions. So most of the studies or most of the evidence has come from patients who have survived. So it is considered that a combination of antimicrobial drugs should be given, and at least 5 drugs having different mechanisms of action should be given. And the various classes of drugs are azoles, amphotericin B, benzimidazole derivatives, pyrimidine derivatives, miltefosine, and even antibacterial agents like rifampicins, macrolides. And they are to be used in various combinations. There is no fixed combination as such. And along with that, the anti-inflammatory steroid can be given under cover of these antimicrobial agents. So these different pathways by which these drugs act, and you should choose drugs having different mechanisms of action, because there is no single drug which acts on the parasite, especially the cystic stage. And if the cystic stage is not killed, it can transform itself into trophozoite, and the infection doesn't get treated. And for Naegleria, the CDC recommends intravenous amphotericin B in combination with miltefosine and fluconazole to be given for a prolonged period. If the person survives, there are hardly 2-3 cases which have survived Naegleria infection. The Acanthamoeba, one of our case has survived the triple regimen of cotrimoxazole, rifampicin, ketoconazole, and this was a child having malnutrition. And lately, a lot of evidence has come for use of miltefosine, which is being considered a miracle drug for meningoencephalitis caused by flea-winged amoeba, and not just for CNS infection, even for keratitis, it's been reported to be a good drug, miracle drug, and MT has approved use of miltefosine even for the topical use. And the survival of these patients who have been given miltefosine in combination to other drugs has been better in all cases of primary amoebic encephalitis as well as for Naegleria infection, and even for the keratitis patients, also for Granulomatous amoebic encephalitis. So, conclusion is that concerted efforts are needed to be made to understand the defense mechanisms that operate against these free-living amoeba, because these free-living amoeba are present everywhere in all the environmental niches and in all parts of the world. However, the infections are rare, but they are increasingly being reported and are actually being considered the emerging infections. And despite advances in antimicrobial chemotherapy, FNA infections have remained significant. There is a very high mortality associated with these infections. So there is a need for increased awareness and strong suspicion based on clinical findings, early diagnosis followed by aggressive treatment using a mixture of drugs. So there is an urgent need to understand pathogenesis both at molecular and cellular level, which will help identify targets for therapeutic interventions and design strategies for preventive measures. So with these, I thank you all for your kind attention, and I would be really happy to answer any queries that the audience may. Am I audible?
Yeah, we lost you for a few seconds. Now you're back.
Okay. So I'm finished. If there are any questions, I would be happy to answer.
Thank you, Sumita, for a very exhaustive and a very comprehensive coverage. And I just wanted to ask you something. Have you seen any survivors from these meningoencephalitis cases?
Yes,
Why?
yes. One case I mentioned that was Acanthamoeba, Granulomatous amoebic encephalitis in a child with malnutrition. So that child survived.
Okay.
It was given a combination.
Most often the textbooks mention that they are almost 100% fatal.
Yeah,
So,
Naegleria infection is almost always fatal. However, Acanthamoeba infections, some of Acanthamoeba infected patients are salvageable. Actually, problem with Acanthamoeba infection is that the infection occurs in the immunocompromised patients. So most of the patients already have an underlying immunocompromised state, which may be responsible for part of mortality which is there.
all right, thank you. So I request Bharti ma'am to give her closing remarks. Thank you again, Sumita, and all those who logged in. Sumita's book is also very good, an excellent resource material, particularly for PGs, because now all the undergraduate books have integrated parasitology. Her book is totally on parasitology, which you will require, and it will help you a lot in your exam prep. So over to you, ma'am, for your closing remarks.
So thanks a lot, Sumita. That was really exhaustive and something at least I have not been reading upon. So it really gained a lot of knowledge and really good work that you are doing. Really proud of your work. And really thanks a lot for the comprehensive presentation. And I think PGs and the young faculty must have really gained a lot. So we would love to call you over sometime even to Jaipur, like we are trying to build up a parasitology section. Dr. Saroj will get in touch with you. And we would love to have your guidance in setting up the parasitology section, because we are just beginning there in SMS. So it will be a great help. And that's a very unique thing. I don't think we have very good parasitology sections, or rather than department. So I think you must be the only one having a department in the whole country. And even the sections are not so well developed.
Thank you, ma'am. Thank you so much for your kind words. And Dr. Sonal, thank you so much for your kind words too. And it would be my pleasure, wherever I'm called, I would be more than happy to
Great.
give any
So
that I may.
we would like to keep a maybe one day CME for we were just thinking have some if you can get some slides, show to the students, and also give lectures, so which should be like interactive and a lot of visuals and also theoretical part.
Yeah,
So
sure.
you give us date, it will be nice. We would love to call you.
Yeah, sure.
Time.
Anytime. let me know. I will be available.
Yeah. So please slot a time for us.
Yeah, sure. Thank you.
And we can connect, Sonal, we can have it online. So like we can have it in a way that others can also benefit.
बिल्कुल बिल्कुल मैम एंड
Okay, okay.
और तुम तो फिजिकली आ जाना.
हाँ, बिल्कुल श्योर एनी टाइम.
सोनल तो कह रही हूँ, तुमको तो सुमिता आना ही है. हाँ,
मैम मेरी
ठीक है.
लेक्चरिंग करती रहती है.
हाँ. चलो,
Ma'am, Sunita
ठीक
is
है.
also hosting our workshop for IAMM, the ones which we've started from 12th, 13th and 14th of August.
Yeah.
So I think that is also going to be a very good attraction for all
Yeah.
the students. We shall soon be rolling out the ad for it. And we'll
Great,
let you
great.
know. Thank you so much, Sumita.
Thank you. Thank you. Okay. Bye.
Thank you everyone for joining.
Okay. Thank you.
Thank you.